Yes,
Yes.
it is.
Bernard, okay? Yeah, so should it start? We'll give ourselves 5 minutes. Within 5 minutes, we should all join in and start the presentation and start the lecture again. And if it's okay, looking at time, because there's somebody who wasn't muted, Manda Emmanuel. Please mute your mic. Thank you. So I would propose that looking at time, there's so much. I've tried to put, we can cover as much as we can. So I would suggest that we go ahead and finish the lecture. Please jot down your questions. We discuss them at the end or in between. If I get a question that's written in the chat, hopefully I'll be able to see through the chats. I'll be able to answer at the end. Is that fine?
Yes, Doc.
Okay, let me just appoint the class rep, please respond so that I know that I'm online. You know, this technology, I may actually fall off and you may not, I may not know that you're not listening, you're not attending, so to speak. Is that okay? We can start. What are your expectations for this lecture today? Judith?
Yes, Doc, I can hear you.
What are your expectations from ophthalmology lecture today? It's filled with the fluid called the ecosystem, and it's about 3 millimeters deep. That angle, it's actually lower than that. And of course, you can visualize the angle of the anterior chamber when you use what we call conio lens. Linda, are you with us? You're busy with something else? Linda? Okay, we move on. So the aqueous that is formed in the anterior chamber goes to the trabecular meshwork through the Clem's canal. Next structure that we look at is the lens. I think we showed it here. This is the lens. That's the lens. It's biconvex. So if somebody asks that, please don't forget. And those are the zonules, as they are called. Structure of the lens, it has a capsule, there's epithelium, cortex, and epicortex. Like I said, it's avascular, it has no nerves, it has nothing, it's crystal clear. And once anything goes wrong, the lens becomes white, which we call a cataract. And please note that it grows throughout life. It has these two functions. It's a refractive media. Let me just admit your friends. This is amazing. It's a refractive media, but not as much as the cornea is. And it's also important in accommodation because for you to see from a distance, you need your lens to focus so that you can read immediately after looking at something, excuse me, that's at a distance. The next structure is called the uvea. Now, uvea is a general term which encompasses, let me just get the picture again, if I can get it. It's a general term that encompasses the iris in front, the ciliary body, and this blue line, the choroid. So when we talk about uvea, we are talking about three structures. the iris in front, the ciliary body, and the choroid. So it's the middle layer of the vascular coat of the vascular coat of the eye. Okay. It lies between the sclera and the retina, and it's the main vascular tissue of the eye. That's the only area where you get vessels. So this is it, blue line that is lying between the pink and the white. So this is where there are blood vessels throughout to the iris. The rest is avascular. Okay. Hello? Are people with me?
Yes.
Yes, madam.
Yes, we are.
I still have people, 7 people trying to join. Okay, we move on. Let's continue sharing that. So the next structure is the iris. Out of the uvea, now we want to describe which part of the uvea is the iris. So this is the anterior part. I think I showed you that. It has blood vessels and of course a lot of connective tissue, and it's pigmented. So each time you're asked the question, what color is your eye? We are referring to the iris. I think I already alluded to this. And this is because it has a lot of melanocytes and a lot of pigment cells. In the center of the iris is the pupil, which is a central perforation. Pupil is a space, ladies and gentlemen. It's not a, rather gentlemen, it's not a space that you can touch, no. It's a space, a hole in the iris that looks black or darker than the iris. It has muscles, smooth muscles, which has, hello? Please mute your mics. Please mute your mics. Okay, so the iris regulates the size of the pupil. When you go into bright sunlight, automatic reaction of the pupil is to close down. The pupil should become small. When you are in dim light, the pupil dilates. And that's the function of the dilator pupillae and the sphincter pupillae. So these are the two that work together to regulate the amount of light or the size of the pupil. Okay. Next structure is the ciliary body. It's also part of the uvea, and like we already mentioned, it's the middle part of the uvea. On the anterior part is the iris connected to the ciliary body and the choroid at the back. So it's the middle part of the uvea, and it's triangular in shape. Function, it produces aqueous humor. It's very important in accommodation. Remember, I said accommodation is where you want to focus on near objects when you're looking at a distance. And your lens has to change its shape to accommodate or to make sure you focus your light rays on whatever you're reading so that the image can be formed on the retina. And that gives you clear image. That is called accommodation. Ciliary body is also very important in that function. And of course, there is drainage of the aqueous humor. Okay. Next structure is the posterior part of the uvea, which is called the choroid. This is what nourishes the outer portion of the retina, and it has a lot of blood vessels. Always remember the uvea is the vascular, the main blood supply is through the uvea. The rest of the structures are avascular, and that's because of the nature of the eye and its function. Vitreous, the largest structure. It is gel-like in children, but in adults, slowly it becomes fluid. Vitreous is in here. It fills up this whole space. That is called the vitreous body. And what is contained in there is called the vitreous humor. So that's the structure we are discussing. So the vitreous is a specialized jelly with connective tissue. It has a volume of about 4 mils, 99% of which is water, and it's located between the lens and the retina. Function, like I said, it's the route through which nutrients go to the lens and also the inner retina. Remember, the posterior retina or the outer retina is fed by the choroid. The inner side is fed by the vitreous body or vitreous humor. And also, as part of its function, it's a shock absorber. When there is trauma, it tends to absorb blackout because that's where vision is processed. And if you have injury to the back of your eye, sometimes the eye may be intact, or the structures in your eye may be okay, but vision will not be there. Ladies and gentlemen, let me stop here. We'll have to join in again when it cuts. Any burning question before we stop?
There's a question on the chat box.
The next thing that we are talking about now is blood supply. Have I answered your question, Mukubeza?
Yes, Doc, you have.
Clear, okay. Thanks. So we go ahead. Blood supply to the eye. Blood supply. Then we get so many other branches, but of importance to the eye is the central retinal artery, which is a branch of the ophthalmic artery. Occlusion of this artery, when we get what is called central retinal artery occlusion, then it's a medical emergency or surgical emergency or eye emergency. Call it what you like, because you lose 100% vision is lost because there's nothing you can do. The retina just dies off because there is no supply to the retina. So it's a medical emergency actually.
Yeah.
The venous supply, sorry. Waluli, do something. Venous. Then autonomy, talking about, for instance, and those are things you see. Cranium, how you see a presented injuries. So we about cranium. We are talking about 4, 5, 6, and 7. Can somebody quickly tell me what these are? What's the first one? Mukubesa, what is cranial nerve 2? Sihoka, what is cranial nerve 2?
Optic nerve.
Sorry, let me just admit your colleagues. It's very distracting. We gave each other 5. Within 5 minutes, we should have finished. Okay. So in the eyelids, we have muscles that are responsible for shutting the eye, that are responsible for lifting and closing the eyelid. At the lid margin, we have lashes, we have openings that we call punctum, and these are two. One, sorry, that's the, sorry, let me not mix it. That is the tarsal conjunctiva. It lines the inside of the lid. So inside the conjunctiva is called the tarsal conjunctiva. Palpebral conjunctiva is also known as the bulbar conjunctiva. It's the one that lines the eye proper. It's sitting anterior to the sclera. The phonoceal conjunctiva is the one that is in the fornix. That is between where the tarsal conjunctiva meets the palpebra. That space is called the fornix. Don't forget, that's a question in the exam. Because of the okay, and it's applied by the autonomic nervous system. So now let's look at this tear film that it produces. This film will cover the anterior, will actually be moisturized by tear film. Another example questions are the 3 layers of tear film. While the tear film looks very small, it's actually got 3 layers. The superficial layer, which is oil or lipid, the middle layer, which is mainly water, aqueous, and the inner or mucus layer. Okay, you understand? The inner is closer to the cornea. The next one is the aqueous. Produces smooth optical surface. It provides oxygen and nutrients, and of course antimicrobial activities, because in there are enzymes, immunoglobulins, all that to fight any infections that may enter the eyes. And of course, the tears mechanically will flush out foreign bodies or even debris. Next thing that we see in the adnexia or in the orbit is extraocular muscles that are 12 in a human being. Take note, it's an MC questions. If I ask, how many extraocular muscles do you have? Don't tell me 6, because the assumption is a human being has 2 eyes. And if there are 6 per eye, that means a human being will have 12 extraocular muscles. Unless I say a human being who has 1 eye, then you tell me it's a total of 6 muscles. I hope that's clear. A human being has 12 extraocular muscles, okay? And the 6 muscles of each eye will control the movements, okay? So what are these muscles? We have 4 recti and we have 2 oblique muscles. I think we'll see them in the next page. I've only put primary actions here because they are secondary actions, they are tertiary actions that may just be a bit confusing at this stage. We'll just concentrate on the primary actions. So for the muscles I talked about, these 4 are the rectus. Remember I said 4 recti, that's plural for rectus. So 4 recti are lateral. If there is lateral, there is medial. If there is superior, there is inferior. You are done with your recti. 4 recti muscles. Lateral and medial, the opposite. Lateral opposite is medial. Superior opposite inferior. All these 4 are recti muscle. And their primary functions, Lateral rectus abducts. Medial rectus adducts. We'll look at these eye movements and explain. And of course, we have the superior and inferior oblique. They elevate the eye and they depress it as well. So when they do these actions together with these two recti, they actually have maximum elevation and depression, depending on which one you're talking about, whether it's inferior or superior, okay? The other homework I would want you to look at is to look at what extraocular muscles, or rather what innervation do these people, what innervation do these muscles have? Nancy, you are late. Niza, you are late. Okay, so what are the eye movements and their terminology? When you look at an individual with two eyes that are anatomically normal, when both eyes are pointing head on or they are looking straight at you, that is called primary position. That is called primary position. The movements of the eyes are in three groups. We have ductions, we have versions, and we have vagances. So when we talk about ductions, we are talking about isolated movement of a single eye. So abduction is the movement of the cornea away from the midline. So if this is my right eye, when the eye moves this side outwards from the midline, it's abduction. When I bring it back in, it's adduction. So those adduction movements. Supraduction, it's the upward movement of the eye. The same way it moved out for abduction and in for adduction, it can move up. So that is supraduction. Moving down is infraduction. Is there a question? I'm getting feedback. I think somebody has. What specific protein from fish is associated with macular degeneration? We'll talk about this later. Okay, so when we look at torsion movements, these are rotatory movements. I've put them in blue, please don't mind them. They are just complications, similar to secondary movements and tertiary movements. Just concentrate on the primary ones, okay? So the versions, for version movements, it's both eyes working together. So when your eyes together move to the right, when you're looking at your head is straight. So when both eyes are in primary position, your head is straight on, and you tend to look to your right. Both eyes will move to the right. That is called dextroversion, dextro, right. When they move to the left, that's linoversion, to the left, sorry. Point of correction, levoversion is gaze to the left. Okay, please make that correction. Dextro, right. Levo, left. L for left, okay. Then when we come to vagances, the vagances, these are equal and opposite movements of both eyes, okay? The first example of a vagance that we have is convergence. When you are writing or reading, both eyes will move in. They are working together, but there's an equal and opposite movement. Okay, so both eyes in this case in convergence are adducted. They've come inwards. Okay, somebody's coming now. So convergence, both eyes come inwards. You imagine you are reading, that movement is called convergence. Together the eyes move inwards. Divergence is From that position, they come back to they come out, they diverge. Both eyes abduct to the primary position. Okay. Next thing we'll look at is imaging. What is imaging? It's the use of specialized equipment to create detailed images to support the diagnosis. So if I see a patient, I'm not able to see clearly whether the retina is thick or not. I would need some investigations that will help me make that diagnosis. So it helps us to support the diagnosis of and also the kind of treatment we are going to give for a variety of eye conditions. So the common ones that we do are what we call CT. This usually just scans and makes images of the layers of the retina. And we use mainly in age-related macular degeneration, macular edema in diabetic retinopathy, or even in glaucoma. Okay. Then the next thing is fundus, what we call FFA or fluorescein angiography, and indocyanine green angiography. Okay, great. Other thing we do is fundus photography. There are certain conditions that are progressive. So slowly, we keep monitoring them. Like glaucoma, for instance, we want to see how the disc is progressing. Then we'll be able to capture and keep those images for future reference so that we compare. There is also what is called anterior segment photography. We get pictures of the anterior part of the eye, or even corneal or imaging the cornea, so that if there's any change, like in keratoconus, there's degeneration of the cornea, we are actually able to see that there is some degradation that you're dealing with. So basically, this is what I thought we could share. So we've done image, we've done eye movement, and we've done anatomy. Are there any questions at this point?
Madam, I have a question.
Yes, please.
On the previous slide, just before this one. Okay. No, not on imaging. The eye movement.
Eye movement.
Yes. The first one.
The ductions.
Uh-huh.
Okay.
Yes, the ductions.
These are the ductions. Is it this one?
Yes. I don't know whether my imagination serves me right. I'm looking at this where you said, for example, if I define abduction, it's movement of the cornea away from the midline. Yes. So now I'm trying to, was this in reference to one eye or both of them?
I think
because
just read the first line. It says ductions. It's isolated movements of a single eye. Oh. So if you are talking about the right eye, the right eye's abduction will be the left eye's adduction. That's why we don't talk about them together. No. Okay. It's clear now, eh? So from primary positions, abduction, let me concentrate on the right eye. Abduction would be the eye moving outwards. So we can't talk about this other one because it will adduct. It's the opposite reaction. Okay. Is that clear, my dear?
It's clear, madam.
Okay. Next question. We only have 4 minutes.
Yeah.
You can ask. Yes, please go ahead. I have a few other students here. Go ahead. Next question.
Yes, Doc.
Yes, that's Manda.
Yes, Doc.
Okay.
My losing of the site.
Yes.
Yeah, what is the correlation between site and the
Kind
same
of
disease?
illness that we have. The problem is the sugar instability, the fluctuations of the sugar tends to damage the blood vessels at the back of the eye. Basically the retina, where I mentioned that they are vascular structure, the retina mainly and the iris. So what happens is when they damage the vessels, the walls of the vessels start leaking. They start leaking fluids, they start leaking so many things. And that causes part of the retina to start dying off because the vessels are not big. The caliber of the wall is not as good to transport the blood vessels to and from the eye, the retina. So what happens is the retina starts dying off. And once that happens, the body starts thinking of plan B. It starts producing new blood vessels, which are abnormal, okay? And that's where the problem starts. It is those new blood vessels that are problematic. And that's why you hear, oh, we are doing laser. We want to kill off those blood vessels, okay? So basically diabetic damages not just the eyes, wherever there are small blood vessels, in the feet, in the hands, in the heart, in the brain, kidneys, but the eye, because it's a small structure, the impact is felt the most.
I get
Okay.
it, Doc.
I don't know if that's, it's just a summary of how best I can.
I've gotten it.
Okay, that's good then.
Thank you.
So we are done.